Good evening, everyone. I'm Dr. Ankit Mistry, and on behalf of Intas, it's my honor to welcome you all in the 34th episode of the Endocrine Talk Show series. And today we will be discussing a very fascinating topic about the vitamins and the metabolic health, where we're focusing on the role of the vitamins in metabolic regulation and the disease prevention, and also the overall endocrine health. And before we begin, I'm very delighted to welcome our moderator for today, Dr. Subhankar Chaudhary sir. Dr. Dr. Subhankar sir is currently serving as a director of the Department of the Diabetes and Endocrinology at Medica Super Speciality Hospital, Kolkata. Now I invite Dr. Subhankar sir to introduce our esteemed panel members. Over to you, sir.
Thank you very much, and a warm welcome once again to our Endocrine Talk Show, which has been going on since 1920, since the days of COVID. So we have been discussing various issues related to endocrinology, which will be of practical help to the physician community as well. And this evening, we have got a very important area of discussion, that's vitamins. It's widely used, maybe misused, and I think we as endocrinologists should take a lead in terms of defining its role in clinical medicine. We all know that vitamins are very important in all aspects of metabolism. And in fact, the various vitamin B complex, all the individual agents are cofactors for various very important metabolic reactions in our body. Vitamin C is important in relation to, let's say, iron absorption, as an antioxidant, for collagen synthesis, and so on. And then vitamin D, of course, is very hot in the news over the last several years, and has been linked to so many different disease conditions. Though, of course, the main issue is in relation to the bone. So we have with us, as usual, four eminent persons from across the country. We have with us currently, we have Dr. Rajesh. So we have got the intro slide for Dr. Rajesh Rajput, who is now the Director Department of Endocrinology at the Medanta Hospital at Gurugram. Formerly, he was at the PGIMS at Rohtak. Can we change this slide? And we have Professor S.V. Madhu, again, physically close to where Dr. Rajput works. So he's Director, Professor, and Head Department of Endocrinology at the University College of Medical Sciences and GTP Hospital in Delhi. Again, a past president of the Endocrine Society of India. We have with us, next one, please, Dr. Kullan Gangopadhyay, who is from Kolkata. He's a consultant in endocrinology at the CMRI Hospital and Peerless Hospitals in Kolkata. And of course, he is a well-known, acclaimed speaker across the country. And we also have with us Dr. Arpunde Bhattacharya, our very dear old friend, who is consultant in the Department of Diabetes and Endocrinology at the Manipal Hospital in Bangalore. He's also Professor of Endocrinology at JJMMC, Davangere, Karnataka. So with these, let us go into the discussion proper. We shall try and cover as many issues as possible, but I think it's essentially the forum for our physicians.
Good
So
evening.
whenever, yeah, good evening, Dr. Rajesh.
Thank you for
So
sorry for joining late.
no problem. So we would request all our participants to put in their questions in the chat box, and we shall try and include them whenever and wherever possible. So let's start with Dr. Madhu. So we start with vitamin B, let us say, and we start with B1, and
हेलो
then we go to B2, which is
आपने
first
लिंक ही
is
गलत भेजा था.
thiamine, and then riboflavin, and then maybe
कोई नहीं,
B3,
कोई नहीं,
which
कर
is
लिया मैं.
pyridoxine, and then
कर
B6,
लिया
and
कर
so
लिया.
on. Sorry, B3 is niacin, and then B6, and so on. So, in relation to thiamine deficiency, we all know about beriberi, but how do we diagnose vitamin B1 deficiency? Do we have standardized clinical tests in clinical use, or is it just our clinical impression that leads us to diagnose this condition?
Thank you, Dr. Chaudhary, and good evening to all. Um, Thiamine deficiency disorders actually are a vast group of conditions. In fact, many of the symptoms are non-specific. As you said, we are all familiar with the common beriberi, the wet and the dry beriberi, which are most common and most explicit of these presentations. But apart from these cardiovascular and neurological manifestations, a whole lot of other systems can be involved, including the respiratory, gastrointestinal, and even indirectly the metabolic and endocrine systems. But the symptoms are unfortunately, overlap with many other disorders, and there's nothing specific that we could say directly tell us that a particular set of symptoms are due to thiamine deficiency. They're grouped under what people tend to call thiamine deficiency disorders. And I think the clinician needs to be constantly aware and have a high index of suspicion for these conditions so that he can try to give the vitamin at the appropriate time or as early as possible. Unfortunately, as far as the tests are concerned, there is no clear-cut standardized test by which you can straight away say or clinic at a clinical level make a diagnosis. Although there are tests to, I mean, there are methods to estimate thiamine diphosphate, but I think not only are they not well standardized, but they're not easily available. And therefore, I think the onus is on the clinician to always be aware and alert to the possibility and make a clinical diagnosis and and supplement the vitamin or treat with the vitamin whenever required.
Right. And one of the areas possibly is in relation to maybe severe acute thiamine deficiency when even without testing, possibly one is warranted to treat with uh, thiamine in pretty large doses. So we come to Dr. Kullan Gangopadhyay. So we do have at least two that I know of, and you can add more if you know synthetic derivatives of thiamine. One is benfotiamine, which is again, I feel, widely misused. And another is salbutamine, which is not so widely used, but still used to an extent. So, do you think they are effective? Do you think they deserve their place in practice? Sorry, please unmute yourself, Kollan.
Yes, can you
Yeah.
hear me now?
Yes.
Yeah. So I think if I summarize the answer first, so answer is no, it is perhaps overused. So I'll just briefly tell you a little bit about what is benfotiamine. And it's basically a lipid-soluble derivative of thiamine. So theoretically, what happens is if there is an excess of glucose, then it can go through the hexosamine pathway and other pathways leading to, I'm just summarizing it for the benefit of the listeners. Otherwise, if I use too many um, biochemical drugs, difficult for me to even for me to remember. So the excess glucose, it stops it from entering other pathways, the hexosamine pathway, creating radicals which are detrimental to the nerves. So benfotiamine stops that from occurring. It is a derivative of thiamine, lipid-soluble derivative of thiamine. There are actually 2 or 3 trials of reasonably um, okayish quality. One is Bendip, and if I remember correctly, another one is Benedip. Uh, one showed just borderline significance, and other one in the intention to treat arm did not achieve significance. And so, therefore, I think although theoretically there is a possibility that it might do benefit in the long term, um, I think we really need good long-term trials to prove their benefit. It certainly has not made its mark in any of the guidelines that I am aware of. And the other one is salbutamine. It is basically a lipophilic derivative of thiamine. So it has got more of CNS penetration. uh, the benfotiamine has got more of peripheral penetration. It has got less of CNS penetration, but salbutamine may cross the blood-brain barrier and has got more of CNS penetration. But again, the trials with salbutamine, thiamine are older and of small numbers, number-wise, number of patient-wise, they are small as well. So all in all, I think theoretically they should work to some extent, but we really need long-term trials to prove it. So whether I will be including them in my treatment of patients with neuropathy, answer is at this point of time, probably not.
Can I ask a question?
Yes.
Kalyan, actually, this is a very important point you have touched upon. But what is the dose of benfotiamine used in Bendip and other trial? Now, whatever drugs which are available in our country, they are actually giving benfotiamine also in subtherapeutic doses. So first of all, the results of the trial itself are not very much encouraging. And then the drug which is marketed in the country throughout so many, and that's where Dr. Shubhankar is actually right. It is overprescribed and with no benefit. So this is just my query.
No,
No,
I
so
think
so
if I remember
yeah,
correctly, the Bendip, I think it was 600 milligrams or something like that
Yes.
of
And,
the
and, and none
benfotiamine.
of the drugs marketed in the country,
Yeah.
it is in that dosage.
I think if I remember correctly, I have not specifically seen how much benfotiamine is there in the various drugs, but I think it's all less than 100 milligrams, whereas
So,
the
so
dose
now
is
you
more
go
than
back and
600.
see. So it
Yes,
is in subtherapeutic doses
correct, correct.
marketed in
So,
our country
yeah,
in name of preventing the complication of diabetes.
correct. So, what I remember vaguely, it's all less than 100 milligrams, whatever I've seen. But I think the trials are with 600 milligrams.
right. So, Dr. Rajput, so we come to you with a similar question as to how do we diagnose riboflavin deficiency?
So again, a
As
very
in,
interesting question, sir. It is a water soluble vitamin, and I actually go totally where Dr. Madhu has said. Most of the manifestations are of riboflavin deficiency are non-specific, which include sore tongue, which include cracks at the angle of the mouth, which include dry skin, some vague neurological symptoms, increased photosensitivity, and per se, if somebody is consuming a healthy diet, until and unless somebody is suffering from malabsorption syndrome or some problems related to the gut, where he is not consuming a good healthy diet, riboflavin deficiency otherwise is highly uncommon. And as Dr. Madhu has told, most of these deficiencies goes hand in hand. So therefore, isolated riboflavin deficiency per se is quite rare, but when it presents, the symptoms are non-specific. So therefore, whenever somebody comes to us with these non-specific manifestation, you can measure level of riboflavin into your urine, but even these tests are not routinely available. Therefore, a high index of clinical suspicion is more important rather than routinely testing them for riboflavin deficiency.
right? Okay. So, but sort of symptoms of glossitis are fairly common.
Absolutely, sir. And whenever we see as I remember even my younghood days, even when somebody is coming for glossitis, we all of us used to write a B complex preparation which contain all type of vitamins. So patient get all right.
I would think so. I'll come to Dr. Arpanda Bhattacharya with a more specific question as to whether riboflavin can have a role in preventing cardiovascular disease, because there's some sort of at least theoretical underpinnings to that, as well as some sort of evidence that it could be an easy way to solve many of the cardiovascular problems.
Thank you very much. I think this is coming for around last a decade or so when we started measuring the homocysteine, and this is probably there is some connection. And the main thing happens on that enzyme that is a riboflavin is a cofactor that is methylene tetrahydrofolate reductase. Now the question is that obviously our redox potential, oxidative stress, endothelial dysfunction, everything depends on that on the cellular level. How much is the practical and how much is the theoretical we have need to decide about. And that does that mean that everybody with atherosclerotic cardiovascular disease, whether it's a cerebrovascular or a cardiovascular disease, we will start giving B to everybody? Probably not. Again, we will go to the same thing. When we are suspecting somebody a deficient state, either because of poor intake or operation, not taking fresh food, we need to think of replacing as a part of other B complex members also. But just like that, there are some data that are mainly in the area of cerebrovascular disease about methionine, somebody which about homocysteine, somebody has a very high homocysteine level. If you give some reduction is there, but how much that translates into the clinical practice is difficult. And I do see a lot of prescription from the neurologist on this aspect, particularly checking their homocysteine and giving. But to the best of the evidence-based medicine, I think we don't have any position now to tell that yes, it will prevent cardiovascular disease. But whenever I am suspecting that this is a setup for the deficiency state, I would not mind to supplement for average maybe around 4 to 8 weeks or so, provided some improvement is there.
Right. Okay. So I think we have a question, Dr. Shushma, but that has already been addressed, which is, are there any reliable biochemical markers for riboflavin deficiency that are feasible in routine critical practice? I think the answer is we do not quite have at this point of time. So we move from B1 and then from B2 to B3, which is niacin deficiency. And once again, we have sort of learned in our MBBS days that the classical B3 deficiency is, the manifestation is pellagra. But niacin has been there, at least in the field of metabolic or cardiovascular medicine, for quite some time, with a role in improving HDL level and possibly thereby providing cardiovascular protection. So what is the current status, let us say, if we, first of all, about niacin itself, and then going beyond niacin, the CETP inhibitors, which is strictly not within the ambit of the vitamins that we're discussing, but because CETP inhibitors are also known to increase HDL, but for a long time, they were not, they were sort of looked down upon, not being effective at all in various clinical trials. So would someone like to take up? Yeah.
Right. So let me take. So see, Dr. Shubhankar, you are right. niacin inhibitors has been tried, and niacin drugs has been tried with quite good enthusiasm in endocrinology and lipidology, but they failed to prove benefit. But now coming to CETP inhibitors. Now CETP stands for cholesterol ester transfer protein. They are actually involved in reverse cholesterol transport mechanism into the body. Right. So they are responsible for transferring cholesterol ester from HDL particle to VLDL and triglyceride and to LDL particles, and in turn transferring triglyceride to the LDL HDL particle. So this is a basic function of CETP proteins. Even they are also responsible for taking up cholesterol ester from peripheral tissues like blood vessels and other tissues. So therefore, the second part which you are asking, initially it was thought that if we will develop CETP inhibitor, they will increase the HDL level, they will decrease the LDL cholesterol level, and they will be good for mankind and will prevent atherosclerosis and cardiovascular events. Now, till date, 5 CETP inhibitors have been studied. The first of them was torcetrapib when years back, but then it has been stopped because of adverse events and increased cardiovascular mortality. Now, till today, CETP inhibitors have not shown the promise what we used to think about. And why I am saying so, if we see the nature in the nature mice model, normally even in the mice, CETP is not present. So therefore, there is no atherosclerosis. In rabbits, there is overexpression of CETP. So they are predisposed to develop atherosclerosis. Human comes in between. So there is an interest of 5 CETP inhibitor, only the recent one, obicetrapib, which has completed phase 3 trial, has shown some benefit. And a very recent meta-analysis published in 2025, it has shown that with use of CETP inhibitor, there is decrease in myocardial infarction and cardiovascular mortality, but there is no decrease in stroke. There are no decrease in other atherosclerotic complication and all-cause mortality. Also, it has been shown now with the research that probably it is not increasing HDL, which is important. What subtype of HDL you are increasing, that is important. We have to understand that on HDL, there are many different types of apolipoproteins which are attached. So if we will increase HDL with ApoC3, it is going to be pro-atherogenic. So probably in the drugs which has been used in the past, it has been shown that there is an increase in ApoC3, which has not resulted in desirable effect. Now the latest one, obicetrapib, now this has been questioned whether it is increase of HDL or whether it is decrease of LDL, which is
Yes.
also happening with the drug, is responsible for cardiovascular benefit. Now, why there is a recent interest, we do not have still any concluding remarks or we have concrete evidence that these drugs are useful for reducing ASCVD. There is a new generated interest that with use of CETP inhibitor, there is reduction in Alzheimer's disease. There is some role in Alzheimer's disease. Even CETP inhibitor when used, which will result in increased in HDL and removal of cholesterol from the ectopic tissue, say for pancreas, reverse cholesterol transport. There is increase in beta cell function and decrease in diabetes. But at the other end, age-related macular degeneration has been found to be closely linked with marked increase in HDL cholesterol. Although trials have not shown the result, but then this is one of the dreaded problems that if we will increase
Right.
HDL beyond certain point, then probably age-related macular degeneration, which is related to the lipid exudation into the macula might be increased. So therefore, as of now, if I will conclude, the current role of CETP inhibitor is evolving. It is interesting. Still, our level of understanding regarding how much LDL increase, which subtype of LDL in HDL, sorry, which subtype of HDL increase will be beneficial is still very preliminary. So therefore, none of these drugs are presently approved by US FDA for treatment of dyslipidemia.
Right, and neither we started with niacin. Neither
Yes,
is that at this point of time of found
absolutely.
favor. Right. So we turned from B3 now to B6, pyridoxine. So I would request Dr. Madhu to throw light upon the link of pyridoxine deficiency with development of diabetes and certain complications of diabetes.
Okay. I think pyridoxine, traditionally, we know that it's associated to some extent with neuropathic conditions, including, drug-related and even diabetic neuropathy. There are some studies, but the interest in pyridoxine and its association with eye complications, particularly in relation to diabetes, diabetic retinopathy, has been investigated. In terms of the levels, pyridoxine levels have been, I mean, if you look at vitamin levels, I think only vitamin D has been tried to show some kind of a association with diabetic retinopathy. Some studies say low vitamin D does have a role, others say no. As far as pyridoxine is concerned, such studies are not available, but what has been looked at is the dietary consumption of pyridoxine. If somebody is taking high levels of pyridoxine in the diet, now this in some studies has been shown, in the long term, even in cohort studies, some of them, that this could result in lower, let's say, incidence of retinopathy or some features of retinopathy in the long run. Or some people even claim 50% reduction. And in terms of treating retinopathy, people have tried combining pyridoxine with few other vitamins, including 12 and maybe folic acid, and found benefits in the short term or 6 months. However, one needs to, at the moment, sound a word of caution that although these trials do exist and these observations, while interesting and do exist in literature, we still need, proper, well-designed, randomized control trials to, have the last word and clear-cut answers whether pyridoxine actually is directly causal or its deficiency is causal in terms of diabetic complications, particularly retinopathy. And secondly, whether pyridoxine supplementation would actually benefit in terms of improvement of diabetic retinopathy. Although I just said that in a 6-month study, which could be called preliminary, has shown some benefit.
Right. So still the jury is open. So
Open.
before we go on to the next vitamin, we have a question in the chat box. Dr. Ashok once again has raised the issue of riboflavin in mega doses has been used for treating various conditions like burning feet syndrome, migraine prophylaxis, and host of others. What is the expert's opinion? And the expert here is Dr. Arpande Bhattacharya.
Wow. Well, if we are using them, I would be interested to use only for a short while. And if there is no benefit, we should clearly take it off. The short while definition will be probably 4 to 6 weeks. And again, the data, so far the scientific data is not very easily available, but the fact remains, you are very right. Whenever you are seeing a significant neuropathy, particularly people with the diabetes, because we treat diabetes, and we do prescribe them. Another area I think is INH ATD therapy also can cause a bit. So we used to give routinely a pyridoxine to
B6.
anybody on ATD.
Yeah.
Can I add something? See,
Yeah.
many years back, Dr. Shumankar, I have delivered a lecture at RSSDA National Forum. Now, because in our country, we are in fashion of writing various types of vitamin B and E. Now, while reviewing during that lecture, what I found was that until and unless somebody is actually having deficiency of any of these,
Mm.
if we supplement with them mega doses, they are actually going to be counterproductive. Even there is association of increased risk of, say for example, cerebrovascular hemorrhagic accident with use of vitamin E and aspirin, which are commonly written in our diabetic population. Similarly, regarding vitamin B, some of the vitamin B are actually associated with increased in risk of decrease in GFR in patients of diabetes if they are not deficient in vitamin. Now we have to understand all of them are water soluble vitamins. So if your body is sufficiently packed with these vitamins, even if when we are giving them, they are just going out into our urine. They are not going anything good. So probably all these studies which our honorable listener is asking, they are heterogeneous. They are treated without actual measurement of riboflavin level to define what is deficient, what is sufficient, and such results we cannot translate into routine clinical practice.
Right. So at this point of time, I think mega doses, any of these vitamins have not been shown to be of benefit and are generally not recommended. And once again, if you do start, as Dr. Arpanda Bhattacharya rightly pointed out, possibly you may try out for a short period of time for a few weeks and then possibly discontinue if there's not been any significant improvement. So we now turn to vitamin B12 and we ask Dr. Kalyan Bhattacharya, who's been silent for a while, uh, is we now talk of vitamin B12 deficiency associated or linked to metformin use. And even American Diabetes Association has its suggestions as to what you should do, how we should measure, should you routinely check for it. So what should be the message for our physicians in India in relation to metformin use and vitamin B12 deficiency?
Okay, so I think oh, I think I'm not audible.
Yes, you are.
I am audible. Okay.
Yes.
So I think the amongst all the vitamins that we were discussing, perhaps in diabetes, perhaps the best studied is B12 amongst the lot, and less of controversy than the others. So I think it is only associated with metformin, and there are multiple theories as to why metformin can cause it, including alteration of bile acid metabolism, small intestinal overgrowth, absorption of the intrinsic factor proper from the gut. And the evidence which is there is from the large BPPOS trial, prevention trial, where they used metformin for roughly around 9 years or something, if I remember correctly. And there, um, just to keep it simple, the the proportion of patients who had B12 deficiency was double in those patients who had taken metformin for at least 5 years as opposed to the placebo arm. So placebo was somewhere around 2 to 2.5 or 3%, and whereas the metformin arm was around 4.5% or thereabouts at 5 years. And this did increase with time. And after about, say, 12 or 13 years, this increased to about 7 to 8%. Many of the observational, there was some meta-analysis which also suggested the same. And it is more or less, as compared to the other vitamins that we had discussed, that there were a lot of inconsistencies. The meta-analysis were more or less consistent that there is a link. And the observational studies suggested that anywhere between 10 to 30% may have some degree of B12 deficiency. But I think we have to also understand what is the definition of B12, whether you use 200 or 250. Some have used deficiency and low B12 or borderline B12 deficiency as less than 200 and borderline between 200 to 300. So these sort of discrepancies are there. However, overall, there seems to be some concordance that the metformin over a longer period of time does cause some degree of B12 deficiency. and that how long is an over a long period of time, at least for 5 years. Whether this results in neuropathic damage, that's the million-dollar question. So there is some hint that it may, but we don't have really very good, big, large trials to suggest that it clearly does so. Um, and the Dr. Kumankar Chaudhary did mention about the ADA. The ADA does mention, and that is the update which they have done this year as opposed to the previous years. They have put in a section that you need to monitor B12 levels in patients who are on metformin long term, but they have not said how frequently you are to monitor the blood B12 levels, and if you are deficient, how long you should be carrying on giving B12 level if the patient continues to be on metformin. So if I summarize it in a nutshell, there is some link with long-term B12 metformin use more than 5 years with B12 deficiency, although it is not 100%, it will be somewhere in the range of 5 to 20%. Uh, the association with this and neurological damage is not that clear yet. There is some suggestion that there might be, it is not that clear yet. So when should we be monitoring for B12? So at least when the patient is on metformin, and it all depends on the dose of metformin as well. They need to be in more than 1,500 milligrams for a period of more than 5 years to cause a deficiency. So those patients who are on more than 1.5 grams of metformin for at least 5 years, we may think about monitoring the B12 levels. How frequently, that the ADA has not recommended. I would suggest that anywhere because B12, it is not easy to become B12 deficient if you have a store. So probably, I think this I'm making a guess that probably every 2 to 3 years, not every 6 months or so.
Right. So can I have a quick opinion from the other participants as also as to we all have been using metformin for long periods of time. So how often do we see? Of course, we don't measure every time, but what's your rough guess, Dr. Arpon, and then maybe the others?
You remember, Shomukha, you remember that NHS, so whenever we are working, the end of 90s, there was a recommendation there which redefined as per Kallan told very strict that anybody on the metformin as a dictum was there that you should check once a year vitamin B12 level. That was something. Now I don't need to check because in Bangalore people will come back with the A to Z and everything B1, B2, B3, B12. So I see a lot of deficient and the low reports. So for my definition wise, as Kallan told, see if 250 to 900 is a range given, I would be preferring somewhere around 400, 500. So whenever I see in the range of 200 to 50, I start thinking to replace vitamin B12, but whatever way I need to give.
Okay, Dr. Madhu, so do you see a lot of vitamin B12 deficiency?
With the problem in our country is it's a little difficult to attribute whatever deficient or whatever decrease in the level of vitamin B12 to metformin per se, because even otherwise, especially in vegetarians, it's not an unusual thing to have a low vitamin B12. So to say or to directly ascribe or attribute any low vitamin B12 level to metformin will be a difficult association, although it is definitely described and it is possible. The second aspect is that many times we tend to treat symptoms of, let's say, neuropathy with vitamin B12 in any case. And so that covers the large proportion of our patients. So specifically finding and treating metformin-induced B12 deficiency while it is described, and even I have seen in few cases, I have not seen in a large number of patients where I can say it's a very common clinical entity to be considered all the time.
Right. And I'll ask Dr. Rajput, there's a question waiting for you. Dr. Abhijit has asked, B12 deficiency with metformin, is it primarily dose dependent or patient specific? And how should this influence monitoring strategies?
Right. So first of all, actually Kalyan has rightly pointed out there are many papers many years back. Until and unless somebody is using more than 1,500 milligram directly for more than 5 years, Metformin use per se is not associated with vitamin B12 deficiency. Number two, whatever we are seeing in our country, people are writing vitamin B12 for so many other reasons to our diabetic patients. So even if it is there, it is not picked up routinely clinically. Number three, if you see the mechanism of vitamin B12 induced, metformin induced vitamin B12 deficiency in diabetes care many years back, there is a paper which shows that actually it is calcium dependent absorption of vitamin B12 from the gut, which is impaired. Therefore, if you are giving only vitamin B12 along with metformin orally, it will not be absorbed because of the mechanism involved in preventing the absorption of vitamin B12 from the gut in patients who were given vitamin B metformin in more than 1500 milligram.
Yeah,
So
Doctor,
there is a
yes,
paper in Quarterly Journal of Medicine many years back which have actually recommended. Again, I remember my old lecture when I have reviewed all these literatures, which clearly recommend that if your patient is receiving more than 1500 milligram and is more than 5 years, then giving 1 gram of vitamin B12 injectable once in a year, it is clearly written into the concluding remarks
right.
of that
Yeah,
paper, will
yeah,
prevent
yeah,
your vitamin B12 deficiency because the requirement is in micrograms. So if we
that's
are
good.
weak,
But Dr. Abhijit wants to know whether the deficiency is individual specific or is it dose specific?
no,
The
there are
larger the dose, is
no such
that's what you said.
information
Right,
that it is individual specific. It is dose
right.
duration
Dose
dependent.
specific. Right.
So
Okay.
people who have intrinsic factor deficiency, it can be individual specific as well.
These are separate.
No,
Arpana, you are right.
those are rare. Yeah.
Yeah, yeah.
But intrinsic factor deficiency is more common in people who are type 1 diabetic, autoimmune disorders. Type
Autoimmune.
2
Yeah.
diabetic, it is quite uncommon.
Right. So,
In
Dr.
other,
Arpan,
just to add to that,
yes.
if
Yeah.
what I was mentioning, if we are, let's say somebody is pure vegetarian, and then if there is no vitamin D in the diet, which is anyway going inside the body, where is the question of metformin induced lack of absorption of
Yes.
B12? That also needs to be considered.
Yeah.
Yeah.
So,
And I think the issue about the calcium interference with the calcium, it is not a proposed mechanism. Not It is not just only that. It's a combination of
There are
various
many.
factors.
There
yeah,
are
yeah,
many.
yeah.
So
Multiple
perhaps
mechanisms. So,
we can overcome that. You see, if I remember correctly, the pernicious anemia was first studied in one of the countries, Scandinavian countries, and there was the first time they, instead of giving injections, they gave oral B12 to overcome it, and they were successful. So intrinsic factor deficiency, you don't necessarily need injection to overcome the B12 deficiency. You give high dose oral, it just works just as well, if not better, preventing injections. So this problem can be overcome by a higher dose given orally, say about 1000 milligrams
Kalyan,
of
why
right.
I have told and bring about the calcium mechanism. Few years back, few of the pharmaceutical companies have started marketing metformin along with calcium supplementation,
Good.
right?
Right.
In our
Right.
country.
Right.
So
So I was not, I didn't know so much that in intrinsic factor deficiency, my first go-to option would be injectable rather than oral. But of course, that large doses of oral B12 can also serve. It's good knowledge. So I'll ask Dr. Arpanda Bhattacharya about which form you would want to supplement your patients with vitamin B12. Dr. Rajput suggested 1 gram of injections, and then of course Kalyan suggested oral. What would you suggest? And we have oral, injectable. We have what do you call it?
We have intranasal as well.
Nasal. Yeah, nasal as well. So I have used the nasal as well. So which one do you use?
Okay, so first thing is that, so B12 absorption can happen two ways. One is intrinsic pathway, another is by mass effect. That's what the colon was telling. If you give orally
Yeah.
big dose, by mass effect, it will get absorbed. So we have it available as tablet form, sublingual, nasal, and injectable. Now, sublingual has become a bit of fashion for last maybe 1 or 2 years because it's available now. So, no probably great difference is there. Somebody cannot take by mouth, can take sublingual, it better absorption. I don't think there is a very clear data. Intranasal, I don't think it has become popular because I think most of the people don't like it, including me. I also not like if you give me like this. So question becomes tablet and injection. Now, if you are deficient, which has been documented, and if you are symptomatic, I would be interested to go for injection at the beginning, followed by oral maintenance therapy. But if you are just a bit deficient and no symptoms or whatever we think can be because of B12 deficiency, I will be quite fine with oral preparation. And regarding injection, our standard advice is actually once in 3 months because 100 days is short of a half life. My once in a year, I'm not very comfortable, although it has been given in some review or something.
But
So
Arpanda,
once you have
that
depleted
is
the
in those
stores,
people, 1000 microgram, 1000 milligram once in a year in those patients for preventing the deficiencies to happen in patients who were on of type 2 diabetes and on metformin therapy more than 1.5 gram. So in
right.
that paper they have concluded. But those who are deficient, obviously we give much more higher dosage.
Once again, a quick comment as to the dosage of vitamin B12. Let's say the the sublingual dose, 1500 micrograms. So we talk about 1 microgram being the daily requirement. So is 1500 microgram a dose that most people will need even if someone is deficient?
Probably not.
Uh, can I add?
Yeah.
Yeah, if we see our old hematology textbooks, if somebody is vitamin B12 deficiency, then what is recommended is that you give one injection once a week for 4 to 6 weeks, and then one injection every 1 month for 3 months. That will actually fill up your body stores. And then probably you does not need that much of higher dosage.
Yeah.
So if somebody is actually deficient, then it means the body is totally empty of vitamin B12. And initially we need to give little bit higher dosage more frequently. Later on, once in 3 months or once in a year, once patient is sufficient will suffice.
Right. And one of the maybe spin-offs of widespread use of vitamin B12s is that sometimes we now find patients coming with vitamin B12 level 2500 or whatever.
Dr. Chaudhary, just a minute before
Yes, yes, Colin.
So I think I was trying to dig through literature
Yeah.
with the pernicious anemia and B12.
But I
I will
didn't
just
say
tell you
that you
why.
were wrong. I said
No, 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 no,
it
no. I'm not
adds to
saying
my knowledge.
no. I'm not saying
Yeah.
I'm
Okay.
not talking about
Okay.
that. I wanted to know
Okay.
what dose they used.
Okay.
Because I remember vaguely that they are used somewhere between 100 to 1,000 to 2,000 milligrams per day. So that was what I was
Milligrams,
trying to
milligrams or
milligrams. Correct.
milligrams. Okay. Those are
No, no,
huge.
no.
Or
It's my
micrograms.
mistake. Micrograms per day.
Okay. Okay.
Replacement, and they this is, I think, I found one article in 2016 where they collated various data with 1,000 micrograms of B12 daily, and they concluded
Orally.
that
Orally. Yeah.
orally
Right.
B12 is an effective alternative to vitamin
Great.
B12 injections. So
That's
I have
great.
been
Yeah.
routine. I've not used intramuscular injections. And
Wonderful.
just to be
Okay.
sure that I'm not wrong, in a few patients, particularly those who are very low B12, so low is less than 200, so I'll put less than even 150. after about 6 months, I've checked the level, and oral just works well enough. It does get it up to normal levels.
And you have checked them as having pernicious anemia. They had intrinsic factor antibody or whatever, antiparietal
So
cell
yes, so
antibody.
I should have checked them for that.
Okay, okay, okay.
They did not
Right.
have any macrocytosis or in their MCV in the hematologic
Okay, okay.
thing.
Fair
So I
enough,
thought
fair
it was
enough.
no
It's
macrocytosis.
Right. So what I'm trying to point out now is that people coming with very high levels of vitamin D being measured in their blood, again, because, Tata 1 mg and this and that, they will do 40 tests, and that will invariably include a vitamin B12. And patients come with 2,500 or 3,000 micrograms, picograms per milliliter of vitamin D. And there is a helpful note at the bottom suggesting that there are so many other conditions which could be associated with high vitamin B12. So how do you counsel your patients, Kollan?
Yes, I think uh, the because there are so many blood tests which are there, and if it is not highlighted, it's very difficult to pick them up. So there's this thick Tata 1 mg. You know how many of them are there. There's this thick blood results, but it is there. So there is a link that B12 levels more than 1,000 nanograms per liter. There is an association between this and solid cancers and hematological cancers. But I think there is a caution that first we have to be sure that the patient is not on any vitamin B12 replacement of any kind, any tablets that they are taking. And second is we have to repeat the test in another lab. If it is more than 1,000 nanograms per liter, then I would probably look at the complete hemogram. Why? Because the CML, polycythemia, uh, thrombocytosis, these are in this hemopoietic lineage. They are the ones who cause higher degrees of hemocorin, that is the transporter of the B12, and lead to raised B12 levels. So, yes, we should be mindful of the fact that if somebody just has got high B12 levels, we should be looking at their complete hemogram, satisfy ourselves that there is nothing wrong with the white blood cells and platelets, repeat the blood test again in a different lab. Then there is no clear guideline as such as to what other tests you would do to investigate. The hematology bit is very clear because you have got the hemogram results right in front of you. Now, do you do the whole body PET scan, whole body CT scan to do it? That is not there. At least I could not get any data to suggest it. So I
Right.
would probably stick to the fact that I would look at the hematology results. That's what is practical, is look at the hematology results first, because they are the commonest ones to cause high B12, if at all.
Right. And I'll come back to Dr. Orpunda Bhattacharya. B1, B6, B12 combination is widely used, including especially by the neurologists, maybe less by the endocrinologist, very little by the endocrinologist, I feel, for all sorts of so-called neuropathic symptoms. So many of our patients come with these multivitamins or these triple vitamin combinations. So what do you do for such patients, Dr. Arpan Bhattacharya? Do you ask them to stop? And they have
Yes,
been on it
I
for
think
long
we should.
periods.
I don't want to be quickly reflexive because it looks like one doctor criticizing another. Firstly, in my mind, I want to make clear that am I treating a deficient state? Is there anything called deficiency? Is there? That's why then I'll try to take the history whether there is an improvement in this therapy or not. There will be some placebo effect, I'm sure. But then when I understand that they are not needed, I think I'll slowly, as I see rigid after rigid, will try to take it off. Because I don't think they are going to do any big advantage. My main problem with the diabetes is that there are 2-3 diabetes tablet, BP tablet, cholesterol tablet, ecospirin, And if you're adding a more number of tablet, my diabetes tablet will take the back seat. That is a big fear of it.
Right. Okay. So we maybe shift from vitamin B12 to folate for a little while. Folate again is very important, at least theoretical involvement in all sorts of metabolic reactions in our body. And once again, the various labs provide you a folate result, whether you need or not, whether the patient needs or not. And so folate level in the blood, does it actually give us an idea of the folate status of that individual? Dr. Rajput.
Right. So I do not know how many of us know actually folate is actually vitamin B9.
Yeah.
Now folic acid is again seen in all type of green leafy vegetables, cereals and pulses. So therefore, until and unless somebody is suffering from malabsorption syndrome or some other problems, folate deficiency is not that common. Isolated. Also, we have to understand folic acid functions in very close relationship with vitamin B12 deficiency. Both of these enzymes work very closely with each other. Now, folic acid is required for DNA synthesis, required for neural tube. That is why all pregnant women are given folic acid, because for baby neural tube development, folic acid normal levels are required, and it is required as a cofactor in number of enzymatic reactions. So folic acid is very important. Now in adult clinical practice, whenever we see a type 2 diabetic patient, and if there is increase in homocysteine level, which is again in routine health packages nowadays done by various labs or even in corporate hospital, homocysteine is routinely measured. So vitamin B12 and folic, both of them are causing deficiency increase in homocysteine level, because folic acid is required for conversion of homocysteine to methionine. We have to understand. Now, therefore, we have to differentiate whenever we see a increased homocysteine level, whether it is folic acid deficiency or whether it is vitamin B12 deficiency. And that is not the question, so we will not go into the detail. But simple measurement, as you are asking, Dr. Shubhankar, of blood folate acid level, which is nanogram per ml, is quite sufficient. There are measures of measuring it in RBC, but again, they are not well standardized, not routinely available. So therefore, for all routine clinical practices, measurement of serum folate acid levels in the blood serves the purpose. We will not only focus whenever patient comes with the report, we will also look at simple hemogram. So suppose somebody is
Yeah.
coming with the serum folic acid level very low, but he does not have any anemia. Patient does not have any macrocytosis. So we have to double check the report, whether actually the report is correct or not. So,
Right.
so, so that's how we will check. Otherwise, there is nothing wrong in measuring serum folic acid level.
Okay. Right. And so you've roughly sort of quickly covered some of the issues of folate deficiency. So can I ask Dr. Madhu, uh, are there any harms of high folate levels? That's a fat soluble vitamin. It should be sort of excluded in the urine if there is any excess intake. But
Yeah.
still, is there any associated harm?
Um, I cannot think of a harm per se, but yes, because it is closely linked to, both DNA synthesis as well as DNA methylation. So several processes which affect fundamental cellular metabolisms are involved, and excess folate might also shift the metabolism from one to the other, and the one carbon cycle gets affected, and this can affect and have potential consequences, including hazardous consequences or harmful consequences. But I'm not particularly aware of
Right.
such side effects
Okay.
in patients.
Okay. If okay, maybe Dr. Rajesh is maybe busy. So Uh, Dr. Arpan, can we sort of quickly summarize the vitamin D status in our
Right,
country?
sir.
Okay.
Ha.
Rajesh is free. Yeah, yes,
Please,
please.
please, sir. Sir, vitamin D status, if we see, if we go across the studies done from our part of the country, like from SGPGI, Lucknow study done way back when Dr. Mittal was there, it has shown prevalence of more than 90%. So the actually the prevalence of vitamin D deficiency depend on what type of population we are studying. And it is true, despite the fact we are living in a sunny country, it is quite common. There are many reasons for it. If we see the wavelength of sunlight which is required for manufacturing vitamin D into the skin, it is 290 to 315 nanometer, that is written in Harrison. But with the today's pollution in which we are living, like in Delhi or in NCR region, entire region, all those sun rays are blocked into their upper hemisphere. So therefore, even if we think somebody is sitting in sunlight in that pollution, probably vitamin D is not synthesized through your skin. And therefore, it is not uncommon to find that even a well-fed individual coming from a very literate person coming having everything, still they are having low vitamin D level. So it's a reality. But whether vitamin D deficiency, second part of your question, is linked with cardiovascular disease. Now, these cause and effect relationships actually has not been proved in any studies. There are associations. There is a difference between association and cause and effect relationships. So therefore, there are association studies that vitamin D deficiency is associated with increased risk of hypertension, increased risk of coronary artery disease. But whether making them sufficient is going to reduce the outcome, I do not think, to the best of my knowledge, any such studies are available which are pure randomized controlled trials. So therefore,
Right.
deficiency has to be prevented, but unnecessary use has to be avoided.
Right. So that brings us to an important issue of when should we ask for a vitamin D test? It is being again widely advised, and many a time, if the patient complains of aches and pains, maybe a little bit of tiredness, and we know most likely there'll be some deficiency of vitamin D, and then we can jolly well be happy, and the patient will also be happy that we have now found a cause for our symptoms. So, can I ask Dr. Kullan Gangopadhyay, what are the indications for doing a vitamin D test, and then does it matter which method and all those? Are those important?
Yeah, so I think, as Dr. Rajput was alluding to, it is quite overhyped, and many a times patients come and tell us that, 1 minute, just a second. Yeah, many a times patient come and tell us, look, the other doctor has checked for vitamin D and he has found it is deficient. You have not checked it. Uh, I tried to tell the patient that in a study with of doctors attending a conference, 80% of the doctors were themselves deficient in vitamin D. Now, this is not absolutely clear that it is clear that we should not be checking for everybody. So that the Endocrine Society guideline has itself says that it is not a screening, should be not used by screening test for each and everybody who is having any tiredness, weakness, not as a screening test. So those who have got history of fractures, those who have got symptoms or signs suggestive of any malabsorption, we should go ahead and do it. Just for a bit of tiredness and aches and pains, I don't think that checking for vitamin D really serves any purpose.
Working
Right.
for hypercalcemia,
So
the
I think
osteoporosis or
so
the
another that's that so then we are moving into different areas where your Dr. Bhattacharya is absolutely right. So many a times nowadays the orthopedic surgeons, I hope there aren't any orthopedic surgeons in our delegate list. They have woken up and they have started measuring PTH level in patients with osteoporosis because they want to start teriparatide, they're checking the PTH levels. So then if the PTH is high, then of course we do need to check for vitamin D deficiency, because more often than not it will be due to secondary hyperparathyroidism due to low vitamin D. So that's an important area. I agree.
So, but uh, Dr. Bhattacharya, so instead of checking for this, because if you agree with Dr. Rajesh and our general impression, maybe 70% of the population, 80% of the population is deficient. So do we need to check for this, or can we not just prescribe vitamin D?
Absolutely right. You'll be struggling to see one of my prescription where I don't write 60K twice a month. And the reason is a lot of people are actually will be writing once a month. I do write twice a month because around 2005 we had done some study in Manipal Hospital, taking a group of junior doctor, senior doctor, lab technician, domestic top, and nurses, and we found that if you are giving 60K once a month, I am not getting level above 40. So although your guideline tell above 30 is okay, but I think for me 40 to 80 is very good level. 40, 45, 60 like that. So very rarely you'll be seeing one of my prescription where the 60K is not there twice a month. I don't
Right,
check. I tell them that tablet costs 6 rupees, the test will cost 1,000 rupees. There's no point in it.
right. So can I ask Dr. Madhu, very important issue that was raised by Dr. Arpandev. So maybe most of the lab reports will suggest more than 30 is sufficient, is good level. But do you think that applies only for bone health, but for metabolic health, we need actually to have a higher level of vitamin D, as was being imputed by Dr. Arpanda Bhattacharya. So we will be looking for 40 and above nanogram per milliliter.
No, I don't think I keep a target of 40 or 60 for metabolic health. But as such, the association is not causally established for many metabolic health indices. There are associations which have been definitely identified. Most of them cross-sectional studies, some of them long-term observational studies, which suggest some link, especially to diabetes, for example. And even supplementation has not been shown to, really alter the scenario. That's one part. So from that perspective, a difference in target for metabolic disease vis-a-vis bone health, I do not think to me is a priority. And and especially for bone health, of course, the PTH response wise, if you say 30 at 30, the PTH response does kick in, and then that target is good enough if you're able to maintain above that. But yes, you can maintain the level even above that. I mean, if you don't exceed and go into the range of hypervitaminosis, it's okay. And especially if you're not monitoring all the time and keep on prescribing, then there can be a risk of hypervitaminosis also. And to that extent, I think even 30 is fair enough, and 40 to 60, if somebody is able to maintain that, also is good enough. But I don't specifically target that range.
Okay. So we are sort of trying to wind up this session. So can we have one comment on vitamin E and MASLD? What is the status? So because we are on vitamins this evening, so Dr. Kollan Gangopadhyay, what's its status in MASLD, vitamin E? Please unmute yourself.
Apologies. So I think first thing we have to clarify is that vitamin E is not licensed to be used in non-diabetic patients with MSLD. And in the
Non-diabetic patients. So they're
sorry, I said
licensed
the
for use
opposite
in
thing.
that.
Not
Right,
in the
right,
diabetic patients, to be used in
right.
non-diabetic patients. I said the opposite. So because it's not been
Yeah.
trialed in patients with diabetes. In fact, there were some anecdotal reports that there's more harm there.
Mm.
Now, with the in patients without diabetes, which is the PREVENCE trial, I think vitamin D was used in a relatively high dose, about 800
800.
units
Mm.
per day. Now, you see, before the FDA had used definitions, if I remember correctly, it is around 2023, that there should be two sets of improvement in liver histology. One is improvement on NASH without worsening of fibrosis, and the other is improvement of fibrosis without worsening of NASH. This wasn't there when the PIVENS trial and the trials before 2023 took place. So therefore, you will really struggle to find agents which are aligned to this FDA criteria. So the similar problem with the PIVENS trial, that it wasn't aligned to the FDA criteria because that criteria did not come in 2023. And it did show improvement in steatosis, lobodal inflammation, and hepatocellular ballooning. But when I had gone through the PIVENS trial, it showed that the fibrosis scores was actually not statistically not improved with vitamin E. And this is important to remember. You're reducing the inflammation, but you are not making a dent into the fibrosis. There are multiple other smaller trials which showed that there was no meaningful reduction of fibrosis with the vitamin E. There were some retrospective studies in patients with advanced cirrhosis suggesting that vitamin E did reduce hepatic decompensation. So overall, if you summarize, vitamin D not in diabetic patients, to be used in non-diabetic patients, it does reduce the inflammation, but there is no evidence that it reduces the fibrosis.
Right. I must say that there's a recent study this year only, but a relatively small study from China, which did suggest that even smaller doses, 300 milligrams, which will translate into about 450 units of vitamin E, has been shown to cause histologic improvement, including, I think,
Fibrosis.
even in fibrosis. But again, that's a very small study, right? So as we wind up, what would be the comment from all our four panelists as to prescribing a multivitamin or multimineral preparation for most of people with diabetes? Even without your prescription, of course, most people are on it. But would you advise, Dr. Madhu?
No, I would not. I'm not in favor of, routinely, blindly, without any consideration, prescribe multivitamins to all diabetic individuals.
So,
We have
what are your
discussed, we have
considerations then?
discussed some of the issues here where specific vitamins might have some role. B12 is probably one of the candidates which might fit in some of the scenarios. Vitamin D, with whatever limited evidence, might fit the role in some cases. But by and large, we need to have more data, more well-designed trials before we can say with confidence that other vitamins have to be routinely prescribed.
Okay, Dr. Rajput?
Right. So we have discussed before I give my concluding remark, vitamin E is a double-edged sword. I have told during the discussion,
Okay, yeah,
there are studies, if you use higher dosage of vitamin E, there is
yeah,
increased risk of hemorrhagic stroke. There is no doubt about it. Cardiovascular protection, HPS and other studies failed to show benefit. So therefore, apart from a specific group of MASALD, routine use of vitamin E again is not rewarding. Now coming to routine
there's,
use
but
of, yeah, please.
no. There's also a suggestion, but of course, one can't do that. Looking at particular genotype, you can identify a subgroup
Absolutely.
of population who will respond favorably to
Favorably.
vitamin E.
Right.
But that's related
That's
to your what's this called, the related to hemochromatosis, the gene.
right.
Anyway, but I'm
Moving
forgetting
from
that.
that
Yeah,
to the last, which you have asked regarding routine use of
yeah.
vitamins, I actually totally agree with Dr. Madhu. I do not personally recommend using routinely vitamin B supplementation for all type of diabetics. So until and unless my patient of diabetes has other comorbid condition, malabsorption syndrome, celiac disease, some other issues where I think there is a pressing need, it does not make a case where patient cannot purchase a normal diabetic medication, but we are making the prescription heavier by writing unnecessary multivitamin supplementation.
Okay, Dr. Kollan.
Kalyan, unmute.
Yes, yes. So I think I think I echo the same thoughts. I think we are on the same page here. For a change, there was no heated discussion or difference of opinion, which is good and bad both. Uh, so we are on the same page, I think. So it is overhyped, um, and overdone. And also, I did suggest about metformin in B12, but also we should not forget our clinics. We should learn to differentiate between B12 deficiency induced peripheral neuropathy and diabetic peripheral neuropathy. Both are different. You can't just treat diabetic peripheral neuropathy with B12 when there is no deficiency. So what are you treating? There is already B12 there. So treat the patient, treat the symptoms, signs, and the patient in totality rather than going just by figures and numbers.
Right. And then the final words of wisdom from Dr. Orpande. Multivitamins for
Right.
people with diabetes.
Unless I suspect a deficiency state or the same thing about nutritional affection, some reason the patient is not able to eat, I'll be giving, particularly some operation, they are going home, I'll be suggesting for short while, again, for a few weeks, and to come out and time, other than vitamin D. So your multivitamin, you are talking about more of a big complex type of thing. Vitamin D, as I told, I believe all of our deficient. I believe our skin is not good enough, whether the pollution or the wavelength of this. And I myself also take, including everybody in the family, we give it every 15 days, 160K. And with the 60K twice a month, till now, I have not seen any level more than 100 nanogram, which is definition of biochemical hypervitamin-D.
Right. So we conclude this session. We had interesting discussion around the various vitamins. There would, of course, be so many other unanswered questions, but it's been interesting and it's been a learning path for me as well. But we do understand that vitamins possibly are being misused, overused, which is not doing our patients any good, maybe providing false sense of hope in various conditions. We do understand that there are definite indications, definite uh, situations where vitamins could be of great help, and our panelists this evening have identified some of them. So we will continue to use them, the vitamins, judiciously, discreetly in a fair number of our patients, including our new thought or sort of newly recognized association of vitamin B12 deficiency in those on metformin, and also vitamin D deficiency being so common in our country. So with these, I would like to thank all our participants across the country who have tuned in, and of course our very illustrious faculty, Dr. S.V. Madhu, Dr. Arpunde Bhattacharya, Dr. Kalyan Gangopadhyay, Dr. Rajesh Rajput. And of course, I must thank the INTAS team for providing the platform for us to discuss these various topics month after month with our physician colleagues. So now
And I
it's
think we should
back.
appreciate the role of the moderator, which is the
Uh,
toughest job, where you don't have a moment to relax or take your eyes off the computer screen. So that's the toughest job, I think.
So,
thank you.
so
Yeah.
thank you
Back to
very
the
much.
Thank you.
thank you.
Good night. Bye. Bye.
Back to the organizers. Any comment?
Thanks a lot, sir. Hello. Yeah.
Yes.
Yes. Thanks a lot, sir. So on behalf of Intas Pharma, I would like to.
Do we have a score this evening? Because
Yes,
in
sir.
other evenings, people have shared how many people have joined.
Yes. Just give me some minute. Yeah, it is around 1800 attendance, sir,
बट वो कोई
That
स्कोर
across
का
India.
मतलब नहीं है ना सर. वो सब लोग ज्वाइन करके अपना खाना भी खा रहे होंगे.
नहीं वो तो ठीक है.
विटामिन ले रहे होंगे.
ठीक है. Yes, Dr. Mr. Brajesh.
Yes. Thanks a lot, sir. So on behalf of Intas Pharma, I would like to give my heartfelt thanks to Dr. Subhankar for carrying this session and moderating this session. It was indeed a great discussion and great learning for all the audience. And I would also like to give my heartfelt thanks to Dr. Kalyan Kumar Gangopadhyay, Dr. Rajesh Rajput, Dr. Arpandev Bhattacharya, and Dr. Madhu SV for sparing their time and giving their valuable insights. Thanks a lot, sir. Thank you.
Thank
Thank
you.
you,
Wish
Ji.
you
Thank you.
all
Good
a
night.
Merry Christmas and a very Happy New
Yes.
Year
Same to
ahead.
you,
Merry
sir.
Christmas
Merry
Thank
and
you.
Christmas,
Thank
Happy New
you.
Year.
Thank you.
Yes.
thank
Thank
you,
you.
sir.
And Happy New Year in advance.
Yes,
Okay.
Happy New
Happy
Year.
Same
New
to
Year,
you, all
sir.
of you.
Happy New Year.
Thank you. Bye. Bye.
Bye. Bye.